everyone, welcome to this month's Suitcase Club. It's our first one in December, so thank you so much for everyone who's joining us today. We have a very interesting talk to you today about rabies, but let's get through the admin things first. Sorry. Okay, so basically for those who are joining us new, we're running a Suitcase Club every month. We just won't have one in January next year, but we'll be back in February. So it's usually the first Thursday of every month. We are in partnership with GeoSentinel, which is a partnership with ISTM and CDC. Basically, it's a global network of travel health centers reporting back on ill-return travelers. So anyone who has contact with travelers who get sick, even if you think it might be an interesting case, please do share it with us so we can submit it as a case to GeoSentinel. It just helps to build up that all the reports and diseases available. And then, as you know, the fire station building is where we are based. So everyone who is online, you're always welcome to come and do it actually in person. We have really nice food. So next time do come and we will make sure it's worth your while. And then this is just the GeoSentinel email address that we do use. So again, if you have any interesting cases that you would like to submit, any ill-return travelers, just send it to us at gos@travel.corp.com and then we will submit it on your behalf. So just a reminder that we do stock malaria prophylaxis at the moment. We do have Lariam and then Malaran Junior at the moment. It is currently quite expensive, but always come and you can submit your queries and then one of our nursing sisters will be in contact with you to help you sort that out. And then we also have the Shingrix vaccine. And then a big thank you to Sanofi for providing tonight's snacks. It's always we're very grateful for that. And again, make sure next time you come in person. So now over to our wonderful speakers, which is a duo team. They are actually, yes, they are sisters, if you can't tell. But basically, they're going to tell us about all the facts from a vet's perspective, as well as a doctor's perspective about rabies, which is going to be very interesting. So I'm handing over to them.
Thank you. Thanks, guys. Right. So we're gonna do it that Ashley's gonna present her part first. So she's the animal doctor, and then the human doctor is gonna do her part next. Okay, so you're gonna go, Ash. Cool. Do you want to use this? Yes. Okay. So some evidence there that we are indeed related. Okay, so from a vet's perspective, we're going to start off from there. So a little bit about me. I was born in Zimbabwe and I qualified as a vet from Onderstepoort in Pretoria in 2021. I started my career working in state and welfare in rural Limpopo for 2 years. So initially at the Mikado Veterinary Lab and following that at the Louis Trichardt SPCA. So quite a lot of exposure to rabies in that area. I have now changed parts a little bit and I'm working in small animal general private practice in Gallo Manor, Sandton. I have got 2 dogs and 2 cats. You can see them in the pictures there. I am by no means an expert on rabies. I am just a GP, but with my time in Limpopo, I did see quite a lot of rabies and suspect rabies. So it's just something that I'm fairly passionate about talking about. Just a little bit on rabies in general, which I think we mostly know about. Rabies is a virus and it can infect any mammal. It targets nervous tissue and it causes encephalitis. It is pretty much fatal once symptoms appear, except for a few exceptional cases, which Dr. Sam will go through now. There is 1 human death every 9 minutes worldwide, and 40% of human deaths are children under the age of 15. 99% of the human cases that are seen have been caused by dog bites, and it's transmitted through bite wounds in the saliva of the infected animal or person if they bite. Rabies is preventable through vaccination. So the goal from the veterinary perspective is to have 70% of dogs in an at-risk area vaccinated, which breaks the transmission cycle. Now, in South Africa, there was quite a cool study done between 1998 and 2019 on all of the positive rabies cases in animals. So that map on the right-hand side is all animals are tested positive. Of all those cases, 59% of them came from domestic dogs and cats. So it's almost all pet type animals that are causing it. Rabies is most prevalent, as you can see from the picture, along the eastern side of the country, Eastern Cape and KZN, and then also right around the top there in Limpopo. Rabies is a controlled animal disease per the Animal Diseases Act of 1984. So that means that the state should be notified of every suspect or positive testing case. In particular for rabies, one positive case in an area constitutes an outbreak. So rabies in South Africa is mainly sustained in 2 cycles. So this sort of graphic here explains how it works and how it goes in between the main host animals and other animals. So the one cycle is the domestic cycle, so it's mostly domestic dogs and cats, and it sustains itself there. And there's also the sylvatic cycle where it's sustaining itself in wild mammals, mainly jackals and mongooses. So you can see frequent transmission enzootically, so within that cycle, between the 2 cycles, and then to non-reservoir domestic and wild animals from the domestic cycle, as well as people, and then infrequent transmission from bizarre non-reservoir hosts, as well as the wild animal cycle to humans as well. So symptoms of rabies in animals can vary really broadly. The main symptom that we look out for is any change in behavior. So a normally sweet, affectionate animal can become aggressive out of nowhere, or a wild animal can suddenly become affectionate or lose its fear of other people and animals. You can also see neurological signs, so you can see ataxia, convulsions, or seizures. You quite often get animals presenting making unusual gagging sounds or having difficulty swallowing, which can be a bit of a confusing case, and a lot of vets end up putting their hands in mouths of cows and things that are making weird noises, and they turn out to be rabid. You also see hypersalivation, you can get pyrexia, dilated pupils. And then one of the weird forms that you sometimes see quite often in Limpopo especially is ascending paralysis. So they don't have any other sign other than just progressive weakness and then paralysis of their limbs. And they turn out also to be rabid. So the form that we are most familiar with when we talk about rabies in dogs and cats is the furious form. It's the one where they're frothing at the mouth and they're trying to eat you and they're really angry. There's also the dumb form, which is what we often see in wild animals that are infected with rabies. They lose their fear of people. They can actually seem to be affectionate and they come, up to people, up to pet animals, seeming like they are tame. And actually that often ends up being a wild animal that's infected with rabies. Diagnosis of rabies. So the virus is present in the saliva, nervous tissue, and brain, but testing can only be done on brain matter in animals. This requires the animal, unfortunately, to be dead. You cannot test a live animal for rabies. This is a pretty difficult conversation to have with a pet owner when you have a suspect rabies case. If you've got a dog or cat in the clinic, it has a history of bite contact, signs consistent with rabies, and it's never received vaccines, I'm feeling morally obliged as the vet to recommend euthanasia and testing. The legal recommendation is quarantine and observation, and then you wait for signs to appear, but it's not always feasible. Oftentimes, if you're working in a welfare setting or in a state setting, there's not the facilities to do that kind of thing. So you end up having to euthanize anyway. Testing in animals, they use fluorescent antibody testing on brain matter. When you are handling any kind of a suspect rabies case, you should be wearing all the proper PPE. So gloves, eye protection, and masks. You must wash your hands and disinfect them after handling an animal. So the system is, it depends on your state vet, whether you collect the sample yourself and send it to them and then they send it to the lab, or you send the whole animal to your state vet and they collect the sample. You have to be in touch as the vet with your nearest state vet. So you euthanize the animal as humanely as possible in a safe way to the person. You double bag them and you send them to the state vet either for processing or just to send it off. The testing is done at the Onderstepoort lab and the Allerton lab. Those are the only 2 accredited places in South Africa for rabies testing in animals. Now, preventing rabies in animals in South Africa. It's a legal requirement in this country that all pet dogs and cats are vaccinated against rabies. The schedule of that, you give the first vaccination at 12 weeks or older. They get another booster 1 to 12 months after that first vaccine. And then the World Small Animal Veterinary Association recommendation is every 3 years for a booster. However, if your area is considered high risk, then they say do it annually. I tend to consider everywhere in South Africa high risk. and so do a lot of vets. Okay, limitations to prevention, especially in South Africa and especially in rural areas. You get a lot of stray animals or animals that are communally owned within a community. There's no one individual responsible for the pet, and it doesn't end up getting vaccinated. There's also quite low compliance rates in rural communities for rabies vaccines. There's a lack of education in these communities. Even though there's high rabies prevalence, people often don't know that it exists. There's also a belief that vaccinating will make the dog weak or sick. And you sometimes hear people say, oh no, the dog needs to have rabies to be a good guard dog, because there's a weird perception that rabies makes them aggressive. But obviously, it doesn't translate that the animal also dies when it gets rabies, unfortunately. There's also quite a strong mistrust of welfare organizations and state vet services in the rural areas here. Oftentimes, you arrive there and you don't speak the language, you're foreign or you're not from the area, and they don't really want you to be injecting their dogs and cats with anything. In addition, with state veterinary services, there's pretty poor coverage of the rural areas, especially in the areas where rabies is at its worst. There's limited personnel, and depending on who you ask, quite bad misappropriation of resources and funds in the state vet services. Now, going on to wildlife, there's a pretty interesting study that was carried out in Limpopo between 1998 and 2022 to see sort of what animals were most commonly diagnosed with rabies. From all the animals that were tested, 22% of the positive animal cases came from wildlife. So not that many, but a fair amount. The most commonly diagnosed wild animal is a jackal and followed by a mongoose. You'll see a few other strange species of wildlife that were diagnosed. Bat-eared foxes, they see quite a bit of further south in the country. And then some other interesting ones like civets and wild dogs. But most commonly, it's the jackals and the mongooses. Okay. Now, the most topical rabies animal at the moment is the Cape fur seal. We're seeing a lot about it on the news and on social media. It first drew attention in about May this year when a pet dog in Cape Town tested positive for rabies. It started to show severe signs of aggression about 2 weeks after the owner thinks it may have interacted with a Cape fur seal on a walk on the beach. Following that, there were colonies reportedly showing aggressive behavior on the coast there around Cape Town, and they sampled 2 seals from these colonies that both tested positive for rabies. After that, everyone suddenly thought, oh, hell, we didn't think that seals could be a rabies reservoir. They then did retrospective testing on samples that they had already for other research and got quite a few other positive rabies cases. They had to use immunohistochemistry for this testing because they were formalinized brain samples. You can't use fluorescent antibodies for that, but still positive for rabies. They got 17 seals as of September 2024 that have been positive for rabies. Pretty scary. We start wondering how it can be introduced into the Cape fur seal population. And then this is pretty interesting. Both of these, the video and the image, come from Namibia. Both of them are black-backed jackals interacting with seals. The video is a black-backed jackal taking a baby seal from its mother, and the photograph is one eating a baby seal. So sequencing on the samples taken from seals showed a relation in their rabies to the canid strains of rabies. So the suggestion is that dogs or jackals were the source of the outbreak. However, the sequencing also showed that there were a few different strains involved in the seal population. There was even a bat-eared fox-related strain involved. So there is possibly that there were multiple introductions of rabies into the seal population. Before the Cape fur seal outbreak, there was one seal in sort of recorded veterinary medical history that tested positive for rabies in Norway. So there's never been a suspicion in the past of rabies in seals. So I think we've maybe been missing it, which is a bit scary. Quite an interesting graphic that shows how widespread it is comes from the Daily Maverick. These are all the positive cases that they've had so far as of about September this year. Goes pretty much all the way along the coast, and surveillance has showed that it's even going further up out of South Africa. Some interesting videos. The video on the left is a seal pup, actually, Clifton Fourth Beach in January last year, going for a little kid. They think this is maybe defensive behavior rather than neurological behavior, but that child was still quite badly hurt by that seal. No one really knows what happened to the seal after that. There was no investigation into it because rabies at that stage was not a suspicion. So just a pretty scary video. And then the middle video is an adult seal that was showing quite odd behavior, biting inanimate objects, chasing people, really uncharacteristic for a fur seal. They're normally quite laid back animals. That seal was removed from that area and then did test positive for rabies. So you can see it's a bit of a scary animal. And then the thing on the right-hand side is taken in Hout Bay. Anybody who's been there seen these fishermen and vendors there. And they have these seals that they get used to receiving food from them, and they use it as a tourist attraction. That is a huge problem, if you ask me. So the tourist attraction problem. There are seals in these areas that are fed and made accustomed to people by these vendors in the harbors. Tourists pay to hand feed or have a photo op with one of these supposedly tame seals. And it's often people with kids or people who are not from South Africa. And honestly, these are not tame animals. They are still wild animals, and there is a huge risk of harm coming to a person in these situations. Ultimately, in 2023, so even before the whole rabies situation happened, the SPCA got involved and removed these seals from Hout Bay and actually relocated them. So that's for the best, because it is an exploitation thing and definitely a risk of harm coming to people. What now with the rabies outbreak? So the surveillance along the coastline in the Western Cape has been increased quite a bit. People have been advised to report any suspicious behavior in a seal to the State Vet Office for them to investigate. At this stage, vaccination of the wild seals is not practical, but there is ongoing research into targeted vaccination of certain populations, so hopefully they will come to a solution fairly soon. Recommendations from the Department of Agriculture also include avoiding interacting with Cape fur seals on the beaches. This is honestly wise for any wild animal, whether we've got a rabies risk or not. It's not safe to interact with a wild animal. They also recommend pre-exposure prophylaxis, so rabies vaccination of all people at risk of or in close contact with the seals. Sam will go through that in a bit more detail just now. And post-exposure prophylaxis, which should be sought out very promptly after any bite exposure to a potentially rabid seal. Got a couple of case studies I'm going to go through now. So I've gotten permission wherever possible for the pictures and videos we've used, and a couple of the animals we didn't have exact pictures of the patients, so I've used a bit of creative license. Hopefully you'll forgive that. So case study number 1. A 3-year-old male Boerboel presents to the clinic for a castration. Why did the owner book at this late stage in the dog's life? The dog has recently become unpredictably aggressive towards his family members. The owner told receptionists when he booked, but it wasn't noted for the appointment, so the vet was unaware. Now, while weighing the dog on arrival, the dog turned without warning and bit the vet on the arm. It's a bit of a nasty bite. Our first question to the owner: what is the dog's vaccination history? And the owner replied, what are vaccines? This dog has never had a vaccine in its life, and it is unknown if he's ever come into contact with other animals. After the bite, the dog became unhandleably aggressive. Even for the owner, nobody could get near him. The vet clinic staff ended up barricading the dog inside the ward and had to call another vet to come in and sedate the dog. After counseling the owner on the rabies risk and the danger of the dog to his own family, this guy actually had quite little kids, the owner consented to euthanasia and rabies testing. Now, question 2. How do we manage the human patient? The vet had a rabies booster 6 months ago. Is this sufficient?
I'm going to ask the people in the room because it's the easiest.
Sister Linda says no.
No.
It's not sufficient.
Not with that one.
No, it's really not. So on arrival at the human hospital, the nurse in casualty said, let's not clean this wound, it's bleeding too much. Let's place a pressure bandage on it. The nurse wasn't worried about the rabies risk here, which is a little bit scary in Limpopo. There were some panicky arguments that ensued, phoning a friend in Joburg who works at the Travel Doctor Corporate, and the wound was then cleaned and flushed out under general anesthetic 6 hours later. A little bit worrying. One Verirab booster was given for good measure while we awaited the rabies test results. Luckily, they came in quite quickly. This dog was negative for rabies. Yeah, he was just a very, very poorly socialized dog. Unfortunately, the breed is pretty prone to behaving like this sometimes. If he had been vaccinated, we wouldn't have been so suspicious of rabies and we wouldn't have had to euthanize him. Personally, I would have recommended euthanasia either way. A behavior problem in a dog that weighs 70 kgs, where it's this aggressive and this unpredictable, is still a danger. Luckily, everybody human came out fine on the other side. Now, case study number 2. A female adult Africanus type dog arrived at a stable yard in the middle of a fairly rural area. She was very, very thin and hungry, but super affectionate, super sweet, very needy for human attention. The people at the stable yard brought her into the SPCA as a stray animal, waiting for her to be claimed because she was so sweet we thought she must have a family. Nobody ever claimed her, and she stopped eating on day 2. On exam in the vet clinic, she had a temperature of 40 degrees, pretty big lymph nodes, and almost white mucous membranes. We did a blood smear and diagnosed biliary, which is a non-zoonotic tick-borne protozoan disease, and we started treatment. It's fairly intensive treatment when a dog has biliary. We put her on a drip, we gave her oral medications by hand, and we were syringe feeding her as well by hand. So lots and lots of contact between vet clinic staff and this dog. She was very sweet throughout treatment, so great. She did really well on treatment, and she started eating again, so we were chuffed with that. Drip came off and we put her back outside in the kennels. And then in the kennels, her behavior changed a little bit. Sudden onset of change in behavior, biting at inanimate objects, biting at the wires in the kennels, intermittently very aggressive, and then affectionate again. So there was absolutely no vaccination history because she was a stray animal. So the SPCA made the decision to euthanize this dog and send for rabies testing. This dog was positive for rabies. Bit of a scary case, and it shows the importance of having all vet clinic staff vaccinated against rabies because the entire staff handled this dog. And yeah.
And how many people were vaccinated?
Of 6 vet clinic staff, 1 staff member had been vaccinated.
What?
How scary is that? Yeah. So vets all get vaccinated, but someone who works reception or the cleaning lady in a vet clinic doesn't necessarily get vaccinated. But actually, you can see in this kind of a case, everyone's hands-on. It is fairly important that every staff member gets one. Shame. Okay. Case study number 3. This is not my case. This is a case that I got from a colleague who was working in the Eastern Cape. This puppy is about 8 months old. He received 1 vaccine at 6 weeks old and nothing after that. His owner was unaware that he needed more vaccines following that. He thought, cool, I'm covered. At that age, it was unlikely to have been a rabies vaccine. It was most likely a 5-in-1 vaccine, which covers against other viral diseases, but not rabies. We most commonly give rabies to puppies that are 3 months and older. So this dog had neurological signs, depressed mentation, limb weakness, ascending limb weakness, and a head tilt. There were limited funds for diagnostics or treatment. The owner wasn't keen on doing much to intervene, so he consented to euthanasia and the clinic decided to send this dog for testing. This dog also tested positive for rabies. You can see it's a pretty distinctly different presentation than the previous one. We expect the dogs almost always to be, biting and aggressive and scary. This is just a depressed, funny, neurological little dog, and he also had rabies. Shame. Now, case study number 4. A trap and neuter and return project was carried out on a population of feral cats in Limpopo. So what this entails is feral cats are trapped, surgically sterilized, vaccinated, and then marked by cutting off the top of one of their ears and released back where they were found. This ensures a feral cat population that's of a controlled size, so they can't breed, and protected from infectious disease. This was actually at a human hospital. So out of the 18 cats that were trapped, one of the female cats, about 6 months old, was noticed a few days later not looking very well. The SPCA inspector was really proactive. He went back out, he retrapped that cat and brought it into the clinic. We were worried about signs of complication of surgery, so we had a good look at her. In the clinic, the cat was pyrexic and dehydrated, but the surgical site did look fine. She was definitely sick, but she did manage to get in a bite during the examination. This behavior is expected in a feral cat that's unaccustomed to being handled, and the vet should have been more careful. It was me. We started supportive care, but this cat's signs progressed quite quickly. She started having seizures and died within 12 hours of hospitalization. Shame. Yeah. So we weren't all that fussed about rabies in this case. It didn't seem all that likely. We carried out a proper post-mortem, and this cat actually tested positive for something called feline panleukopenia. So that's a little rapid point-of-care test that we use called a SNAP test for parvovirus, and that is what panleukopenia is. Positive for that. It does also cause neurological signs in cats, so pretty likely to have just been that causing her weird signs. Because of the bite exposure, we did still send the brain off. Now, once again, we have a human patient. You. The vet went to a Dis-Chem clinic for a tetanus and rabies booster, per the advice of her sister, who is a human doctor. She was advised by the nurse in the clinic that cats cannot transmit rabies, so a rabies vaccine would not be necessary. The nurse also advised that you can't give a rabies vaccine and a tetanus booster at the same time. The vet here knew that the nurse was incorrect and sought out the correct care, but if the patient had been uneducated on rabies, was just a person off the street that was bitten by a cat, and went to seek help at this clinic, it could have ended in death, actually. So, pretty scary case, this. The cat, in this case, did test negative for rabies as expected. Now, limitations to our diagnosis of rabies. In case study number 1 with the Boodle, this was an owned pet from a home. The owner was trying to do the right thing to correct his behavior by getting him neutered. Unfortunately, he was unvaccinated, aggressive, and a bitter person. These altogether were enough to warrant euthanasia and testing. In case study number 2, we've got concurrent disease, and it does have a cerebral form, biliary, and it can cause neurological signs. So that was a big confuser. We totally missed the early signs of rabies in this case. In case number 3, the dog had received a vaccine, and unfortunately, the owner thought that that was enough and his dog was safe. Once again, there were other differentials, other things can cause those signs, and we couldn't really rule them out without testing the dog for rabies. And then in case study number 4, it is pretty scary that people do not know that cats can contract rabies and transmit it. Again, we had concurrent disease causing similar signs that were confusing. But in this case, there was lots of chatting between the vet and the human doctor involved, and Prof. Blomberg was ultimately made aware of the incident and initiated some training for the nurses in that area. So good outcome in the end. Okay, that's all I've got for you guys today.
We've got a question in the room.
Yes.
How long does it take to get the rabies test results back?
Depends. Depends on your state vet. So it's fairly difficult to get the sample all the way to Pretoria if you're in an outlying area. We managed to get them sent off fairly quickly when I was working at the state lab in Limpopo. If you collect the sample on a Friday morning, it will only go on Monday. And then when it gets to Pretoria, it takes about 72 hours, and then you've got results back via email. So if it's at the end of the week, a bit longer. If it's on a Monday, you'll get the results by Thursday or Friday. So fairly quickly.
But it's still like quite a long time to not know.
Quite a long time if you're sitting in hospital with a dog bite wound, yeah.
Yeah. Especially that was managed like that, where it wasn't the post exposure wasn't given accurately. The wound management wasn't done. Yeah. So
I have a follow-up.
Yes.
So there are not that many rabies cases in dogs in the Western Cape. So they're sending all these seals to Pretoria.
yeah, to actually diagnose. Yeah.
Because there's
Do you send them on us? I mean, how do
Yes.
you actually?
So you can preserve the brain in glycerosaline, or you can send them on ice. Most of the time, other areas other than Limpopo send them on ice because it's quick. Limpopo sends them in glycerosaline.
Slow.
Yeah.
Yeah.
Awesome. Thanks, guys.
Okay.
So
Thank you.
that's Ash's details. Right. So I'm just going to do the human perspective. Some of the information Ash has already covered, so I'm not going to necessarily go through everything on the slides, but whenever something is important, we will stop. About me, so also born in Zimbabwe, surprise. And I also studied at University of Pretoria. I did internship at Barra and my comp serve at Helen Joseph. And then I came to work at Travel Doctor Corporate, and I've been here ever since. I also have animals. I have a husband and 3 cats. Right, so just some of my qualifications, just some mostly travel medicine related HIV diploma as well. So I'm going to be talking a bit on rabies in humans specifically. So obviously rabies, as we've heard, it's a viral zoonotic disease. It causes a progressive infection that actually goes and attacks the nervous system of the host and causes inflammation of the brain and spinal cord. We didn't really speak too much about all of the genus and all of that stuff, but you can see it's caused by the Rhabdoviridae genus Lyssavirus. which are transmitted in the saliva of the infected host, and then would, through a penetrating wound, would then go and infect a human in this case. There are tens of millions of human exposures every year. I've put a little bit of the information into more of like a graphic thing. It causes around 59,000 human deaths annually, and this is in around 150 countries across the world. Of that, 95% of the cases are occurring in Africa and Asia, and mostly occurring in rural areas. 40%, as she mentioned, are in children under the age of 15, and 99% of the cases are due to dog bites. Right. The incubation period, and this is where things become very tricky for us when we're dealing with post-exposure cases. It can vary from 1 week to a year, and even longer than that. Up until, I think we've got our maximum case was, I mean, we spoke about like 8 years or something crazy like that. Though typically it's about 2 to 3 months. Your early symptoms would be usually just a non-specific fever with some pain, and then unusual tingling, burning sensation. So your paresthesias around the wound site. Again, they're 2 clinical forms, and they kind of follow on from the veterinary ones. So we've got furious and we've got paralytic. So your furious rabies is the one that we've all kind of seen: hyperactivity, hallucinations, excitable. This is where you see the typical hydrophobia, and in some cases aerophobia. So people actually get afraid of like fresh gusts of wind on their face. And then death usually occurring quite quickly here, so within 3 days or so. And then paralytic rabies, which is only about 20%, although vastly underreported because it does not look like rabies. So it's kind of just this ascending paralysis, like what you spoke about, eventually causing coma and death, and much less dramatic. And yeah. Dog-mediated human rabies is obviously the main culprit, 99% of cases, and making people aware of this is obviously paramount to stopping the transmission cycle. And I think you spoke to about 70% of the dog population needs to be vaccinated in order to stop the cycle. This is just a video with a child who had been, obviously was confirmed
behavior
with rabies.
He tries to escape when his mother presents a moistened cotton wool.
I don't know if the sound is coming through.
His hydrophobia. He demonstrates some gagging and difficulty swallowing.
So the mom in this case has actually got water that she's stuck up with some cotton wool, and she's trying to feed the child some water. And the child is just terrified of the water, so will not take any water, and then is also gagging, can't swallow properly, so very typical hydrophobia symptoms. I'm sorry, the sound might not come through on the meeting, but I'll just explain. I didn't share my sound.
There is only one condition that makes you deathly afraid of water, and when symptoms appear, it's nearly 100% fatal.
It's ridiculous. So, yeah. So just absolute terror when exposed to water.
Rabies.
And yeah. Okay. So just a little bit of what's going on at the moment, and we've spoken about what's happened in the Cape Fur seal population. This is just a little bit of history. So our SASTM, the South African Society of Travel Medicine Centre, was the news flash that went out from SASTM, and it was on the 7th of June to say that there was a rabies case that had been picked up in seals. We then made the international news. This was Shorland Travak sending out the 15th of July to say that they picked up this rabies, and that certain travelers should be vaccinated. So we're going to go into this a little bit later, but what does certain travelers mean? And it's always a little bit difficult. So what we did then from our side as Travel Doctor is we put out some sort of social media, a little bit of an email campaign to say we've identified certain areas where there is an increased risk. And I'm going to go into that a bit later as well. And this was basically to an open water swimming event that one of our doctors was taking part in, to say, if the people who are swimming in the ocean, are going to be exposed, and they will be exposed to seals, they often come and swim next to them and sort of nibble at them. Please, they need to be given pre-exposure vaccine. All right. This is just a little bit of on the 28th of September, that's World Rabies Day. The city of Cape Town announced that the rabies virus was considered endemic in the Cape fur seal population. The public health advisory remains still to this day that pre-exposure vaccination is not recommended for the general public. Once bitten, however, obviously you must seek immediate medical attention and receive post-exposure vaccination. All domestic dogs are to be made up to date, which they should be anyway, and then ensuring the dogs don't have contact with seals. So this is also difficult because lots of people take their dogs to the beach and they run, and if they're in a seal that's behaving abnormally may actually come out and attack a human or a dog. Seal feeding obviously remains illegal, and aiding and abetting of those seal feeders that Ash showed us is actually an illegal act, and you can actually be arrested for that. Public to stay clear of all the coastal wildlife, also mentioned, and any seal that's behaving unusually or aggressively should move away immediately, and then obviously notify as well. What do we recommend? That's the sort of Cape. That's the public thing. What do we recommend as travel doctor? We always say it's better to have pre-exposure prophylaxis, and that's for a number of reasons. We are dealing with travelers that may be traveling into areas where they're not going to have exposure or may not have availability of post-exposure prophylaxis. Obviously, if you are vaccinated before, there's going to be less anxiety if a bite does occur. No need for expensive rig, fewer jabs after exposure. There's a long list of why we should do it. But not always done. High risk activities, again, big question mark. What do we consider high risk activities? So I put there at the top the open water swimmers, because we've got some close to home examples of that. Divers, avid surfers, marine biologists, vets should already have it. And then harbor workers, the list can get very long. Anyone who's got an exposure to anywhere along the coast actually has an exposure to a seal, and anyone who wants a vaccine. This is a difficult question because are we saving vaccine for people who are at high risk, or are we able to give it to people who want it to be safe? So this is what I was talking about. This is the seal. You saw her at the start. You can see a little dot floating in the middle of the ocean there. That's her. She swam 12 kilometers, open water swim in the ocean. Didn't see a seal on this occasion, but they're around. She is, however, vaccinated. So good travel doctor employee, up to date with her vaccinations. There she is again. And this was when you swam to Robben Island. And yes, there she is again in the water in the middle of the ocean. So yeah, it's just an important thing of people who are doing these sort of outdoor adventure activities to just make sure they are our high risk population. This is a question I've gotten. This is actually my husband asked me. I said rabies is 100% fatal. He said it's not. So he's right, because there are 3 recorded cases of people surviving rabies. So Gianna Gisa, I'm probably butchering her name. She was a 15-year-old American girl who contracted rabies in 2004. She was bitten by a bat. It was not picked up at the time of exposure. She then proceeded to actually develop full-blown rabies, seizures, hallucinations, and paralysis. She was taken to the hospital quite late after the development of the symptoms, and the doctors actually put her in an induced coma and then administered, they just say antiviral medication. It's quite difficult to get your hands on what they actually did, but she was basically ventilated and then slowly weaned off and actually survived. She actually made a full recovery. So if you have a look on the screen, that was her being ventilated in the hospital. This was the day she was discharged from hospital. She was still quite weak at that stage. She could not stand up on her own, but she went through quite intensive rehabilitation. And this was her giving birth to twins I think that was in 2018. She had babies. And then this is her in 2022, actually talking it's a children's center on World Rabies Day. She basically goes around and educates people about rabies. So very interesting case. And it also lends itself into this very interesting study that was done by published in the Lancet in 2019, and focused on a small population in the Amazon of the Ashaninka people. They live sort of in this area between Peru and Brazil, and it's a small population of about 55,000 people. They were studied, and it was found that about 10% of this community had developed antibodies against rabies. Whether those antibodies were protective against rabies, obviously we're not going to be able to test that for obvious reasons. But none of them had received a rabies vaccine. So they had antibodies. Whether they were actually fully protective or not, we're not sure. They believe that this came from repeated small exposures through bites and scratches from infected animals, and that would most likely be the bats that are endemically infected with rabies in that area. So just something interesting that can occur. Just a bit then a little bit about rabies itself. So this is more of the content side. It is found in all continents except Antarctica. There are quite a number of different species that exist, of which 7 of them are known to cause rabies or rabies-like infection in humans. And it causes that in all mammals, which we did speak about. Importantly, obviously, the canines, like we said, and then bats and any wild and lots of wild carnivores in the Americas. In the US, one of the major animal reservoirs are bats, raccoons, skunks, foxes, and mongoose is just everywhere. So they seem to have it wherever you go. And they are quite confined to specific regions in America. In Hawaii, there's obviously the bats that we speak about, and they're a very common vector, accounting for about 70% of the human rabies deaths in the US. Obviously, down at the bottom here, we've got more of all around the world, but it's just interesting, obviously, in Southern Africa, kudu, jackals, any kind of mammal, you can get it. So this is now travel data. So of the 23 cases reported in international travelers in the 6-year period between 2013 and 2019, 57% of them were in Asia. A lot of those are coming from the monkey. So it's the 2 major monkey visiting areas that people get exposed to. So a lot of monkey stuff, obviously stray animals as well. 30% in Africa, and then 4% in Central America. It does occur worldwide, but interestingly, nothing in Japan and New Zealand. It's nothing seems to happen in New Zealand. Right, so rabies mainly transmitted, like we heard, through saliva, but there's actually 3 ways that can get into the body. So we've got a person with intact skin, which would obviously have to be a bite or a scratch wound, then licking of a non-intact skin, so that would be anyone who has a cut on their hand and it gets in through that, and then onto mucosal surfaces via saliva or contact with infected neural tissue. And interestingly, this is where you can actually inhale rabies, and this would come in mainly in the lab workers that are working with rabid samples. And Ash told me something scary, that the guy that used to cut the brains open when she worked at the lab didn't used to wear PPE. No. And that just, I think he's one of those Peruvians that has antibodies, because you're obviously now getting the whole everything coming up. He uses a big, what is it?
A table saw.
Table saw to saw into the brain, and there's brain matter going up. So very, very high risk, I would say. And then it enters the peripheral nervous system, and then basically travels through the peripheral nerves into the central nervous system. Bat rabies mainly, okay, we spoke about the scratches and the bites, and then that aerosolized virus and bat saliva. If there's a cave where there's lots of bats that are congregating, it can also be basically inhaled or aerosolized from that. Bat bites, I'll get a little bit into that later with pre and post exposure, but bat bites are always considered, or bat exposures are always considered high risk, because they're so small, and it often goes as we're not really sure if someone was exposed or wasn't. I thought this was a terrifying line. Human to human transmission has never been confirmed, but is theoretically possible. So I know it's not, we hopefully won't be having rabid people going around biting, but people often, especially the lay public, talk about this as the zombie virus. So it is possible that we can start biting and infecting each other through human to human transmission. Okay, so just a little bit of a recap. I did put this in because this is what we use here. WHO categories, very simple. Category 1, these are categories of exposure. Your category 1 is you have just been licked, you've touched an animal, there's no open wound, it's basically no exposure. Category 2 is if you've had any kind of minor scratch or abrasion with no bleeding, that is considered an exposure. And then your typical category 3, like we saw, major bite, scratch, there's been a severe exposure. Then you get the CDC and they just make everything complicated. I really almost took this out, but I wanted to show everyone how complicated it is. So this is the CDC's recommendations, and then it goes, and each different category has a different kind of vaccine series that needs to be given. They talk about unrecognized and recognized exposures. They actually do titers after giving some of the vaccines. So we don't do this. They are not in line with the WHO. We actually prefer to do just WHO, which is much better for resource scarce environments, because this is like labs and multiple visits to the health center. Clinical presentation, we say the period is variable, 5 days to several years. It can be obviously quite rare, but usually that's 20 to 60 days after exposure. Just interestingly, what is the risk of where it depends on where you've been bitten. So you can imagine wherever there's a lot of nerves or it's close to the brain. So there, the head, 55% chances if you've been bitten by a rabid animal of it developing into rabies. This is obviously someone who doesn't have any pre-exposure prophylaxis. Upper extremity, 22%. We know our hands are full of nerves, so it's going to get taken up very nicely there. Trunk, 9%, and then the lower limbs, 12%. Okay. Right. Very difficult to diagnose in a human because, like we said, you can mainly only do testing after the patient is already deceased. We would say you get this like a little bit of paresthesias around the area that they've been bitten, and then it develops into a headache, myalgia, depression, and then it depends on the kind of rabies that they're going to develop, the clinical kind. So your furious rabies, you're going to have all of those typical symptoms, like we said. 3 to 5 days, they're gonna go. Paralytic rabies, much longer course and obviously very different to the typical furious type. And obviously canine rabies is actually 100% fatal. Of the 3 cases that have known to have survived, they were all bat rabies virus, and they think that there's something to do with it being slightly less virulent. So there's a higher chance of you actually recovering. No, never having recovered from a dog bite. Rabies prevention, this is just a little summary. So you've got your pre-exposure prevention and your post-exposure. Each one has a non-vaccine and a vaccine. So pre-exposure would be your education of the public, avoiding contact with all animals really, wild animals, stray animals, people's pets. You don't know if they've been vaccinated. Unfortunately, not everyone can do that. So it's some people's job to have exposure. In that case, we've moved obviously to the vaccine. So you've got your pre-exposure prophylaxis rabies vaccine 7 days apart, and then valid for the life of the vaccinated person, unless they are high risk, like in veterinary practice and people who are getting exposed often, they would then need boosters. Post-exposure, and again, I always find this quite interesting to see how it's actually done. So thorough washout of the wound, they say for at least 15 minutes immediately. So we can already say didn't happen. Leaving it open, didn't happen. And then some cases may need debridement. So that at least did happen, but a bit late. And then antibiotics may be required, obviously, just for co-infections and things. And then your post-exposure prophylaxis, and I've got a bit of a nicer slide on that, because that is depending on whether or not the person had pre-exposure. This is just a little bit more detail of what to tell your people. But it's all pretty much, you think common sense, but it's a good thing to just touch on it. I think the biggest thing here is people don't know that that rabies risk even exists. So it's even just bringing it up with your travelers when they're coming in to say, please don't touch animals when you see them, because there is a risk where if they're going to an endemic area, especially. And then you've got your PrEP, and that is the decision to give PrEP is very individualized and based on the destination of where they're going, how long they're going to stay for, what type of activities they're going to do, the age of the traveler, and obviously also, is there vaccine and rig available where they're going to go? And I actually hate that one because we don't know, and we don't know if they're going to have if they're going to be able to get it, and how long is it going to take for them to get it. So I don't like the idea of ever saying to someone, oh, it's fine if you get bitten, just go to the local clinic, they'll sort you out. So don't like to do that. Post-exposure we've spoken about, but washing the wounds out. They talk about this, if possible, keep the animal under observation for 10 days. I mean, no one's going to be able to do that. And then your post-exposure. So your vaccine, depending on whether someone's gotten PrEP or has not. And then sort of a few little bits and bobs on how to address it. Obviously, all category 2 and 3 exposures should get post-exposure prophylaxis. And then the bats. So any kind of other animal, we know category 2 and 3, easy, give it. Bats are a bit of a different story because we don't always know if there's been an exposure. So we will say any kind of being around a bat is kind of an exposure, unless you are absolutely certain that that bat did not bite you or come into contact with broken skin. I wouldn't know for sure if that had happened, especially if you're sleeping in a cave where there's black bats flying around you. And then they say you can discontinue the post-exposure if the animal has been determined to be rabies free. What we would usually do in a situation like that is still complete the 2-dose course, so then the person at least has pre-exposure as their post-exposure. Right. What do we have access to in South Africa? So we've got 3 products generally that we have access to. Verorab is our rabies vaccine. It's used both for pre and post-exposure prophylaxis. And then we've got Rabigam, which is our rig, and that is actually human rig. And I've got a bit of an interesting slide just now. I'll show it to you. And then Equirab, which is the one that comes from horse serum. So that is available in some centers. It is made in India, so it's brought in, I believe, under Section 21. We don't generally keep it here because we have access to human rig, but a lot of the hospitals in Joburg will only have equine rig. The risk there is just if someone has some hypersensitivity to anything horsey related. Right, so there's what we have in our fridge. Just a little, so obviously Verorab and then the Rabigam. Linda, I wanted, but I didn't check before. How much does it cost for 1 vial of Rabigam?
That's something like
I think it's even 1,000. Yeah. So that's and that is, yeah. And there's only 300 units in this little vial, so it's 150 units per ml. And then I thought the little package insert was cool because it says here that it contains gamma globulin derived from pooled human plasma sourced from non-remunerated healthy donors with high titers of antibodies to rabies. So I just popped this slide in here because that is one of our non-remunerated donors giving her plasma. And then they used to, this is not part of the remuneration, but they were students and they used to pay them in food. And tickets to the movies, which I actually benefited from as well. So it was quite nice. It's very cool because they take the blood out and then they take the plasma and then they put the pooled blood back inside. Right. Okay. Yeah. So you can actually donate every 2 weeks. Yeah. Monoclonal antibodies, I'm not even going to really go into it. We don't have this available in South Africa, but there is a bit of research going into this as a replacement for RIG, much less adverse events, and actually they think it's going to be a bit better, easier to administer and things. Okay. These are just specifics about vaccinating our human patients and when we would consider postponing PrEP or PEP actually. PEP postponing doesn't generally happen because the risk of developing rabies is obviously just like the 100% fatality is going to go over. But sometimes PrEP can be postponed if someone is very ill at the time, like any other vaccination. The contraindications would be previous anaphylactic reaction to any of the vaccination or the vaccine constituents. And then obviously the history of severe hypersensitivity as well. Okay. These conditions are not contraindications. So a lot of time people think these are, they are not. People can still be vaccinated if they have any of these issues ongoing. And interestingly, Guillain-Barré syndrome, we had that as a case. Special considerations, I didn't really go into this a lot, but bleeding disorders is obviously always going to be a thing with vaccinations because we are giving an intramuscular vaccine. A lot of the times if someone's on any kind of anticoagulation, we would say they would have to omit one of the doses or two of the doses before they get vaccinated, but that goes for all vaccinations. Immunocompromising conditions and HIV, a lot of the times when we're vaccinating someone and we're not sure of their immune status, the only problem there is we don't know if they've actually mounted an adequate response to the vaccine. And always in the States, they will just fall back on, we're just going to do the titers. And it's not actually feasible here for us to do that. So it's a bit of a gray area for us. Obviously, if someone has been exposed and they are HIV positive, we would just give the course, but we would actually probably err on the side of caution and give them more doses of the post-exposure vaccine. Pregnancy and breastfeeding, obviously, if the person has been exposed, you give it. There's no issue there. And then compatibility. So again, and this speaks to the whole Dischem story, you can give it with any vaccine. There's no contraindication to administering it with any other vaccine. And it obviously is made safe to be given with RIG, but the only proviso there is that RIG should not be given after 7 days of initiating a post-exposure vaccine, because then it would interfere with the vaccine response. So if you don't have RIG available and you've started the person on post-exposure vaccination, you have 7 days to give RIG. After that, don't do it. And then all the other immune suppressive could, interfere with the development of immunity. And then they always fall back on, in these patients, consider testing for antibody response. America. Just a little interesting thing on the literature. So there's been a bit of research that's gone into, are we one and done? Can we just give one rabies pre-exposure dose? So this was a study that was done, divided into groups into 4 different groups, where they actually had one group just getting 1 single dose, another group getting 2, the normal, and then as an ID, and then 2 as an IM, and then no rabies vaccine. And then what they did is they simulated an exposure. So these people weren't actually exposed, but they basically said, okay, cool, 6 months later, let's check if what happens now if we give them PEP. They don't actually give them an exposure to rabies, but this is what happened. You've got your 1 dose IM, and this was then after they've had their PrEP, and then they received their first dose of PEP, and then you see 2nd dose, and then by the 3rd dose they were above. This line here is representing where they actually are safe. They have enough antibodies, and so they choops over there, they go. This is 1 dose, very similar response. Up it goes after the 3rd. This one was 2 doses of IM, and they were above the whole time, so that's still better. And then this one was no PrEP. And then obviously they only go up after the 4th dose, sorry. So yeah, so that just interesting. Obviously, it doesn't mean that we can just start going over to 1 dose. A lot of people weren't tested, a lot of different groups weren't tested. But our thing that we use in our clinic now is 1 is better than none. So if we're going to see someone once and we're not going to see them again, we're going to give them 1, which is different than what we used to have. So these are just my references. I used a few different sources just to get a bit of an overall view from the different parts of the world. This is my further reading section. I don't always like to read, but watching a video is always quite nice. So these are just interesting YouTube videos I came across when I was doing research for this. So just cool where the rabies vaccine comes from and actually how it was developed. It was actually the 2nd vaccine to be developed in the world after smallpox, and then what happens to a human if they get rabies. And the links are there. I can post them afterwards. And that is the end.
Wow.
Thanks, guys. Good. So we're going to take some questions if there are any, but I'm not going to, sorry, my slides were very long, so I'm not going to keep everyone much longer. Are there any questions on the chat? I know Albie's there, so please ask away. And Renette has one in the room.
To the vet. So we're assuming that all animals that are rabid will die. Okay, I'm specifically thinking about bats because I'm most worried about them. Do you know if a carrier status of this virus has ever been shown to exist?
We are taught that no carriers for rabies exist. A rabid bat will die of rabies. A rabid jackal will die of rabies. So you don't really get a healthy animal that's carrying rabies.
So it won't be for too long that animals will be flying around carrying rabies.
Yeah, I think the big thing in a lot of those, like the bat population and now in the seal population as well, is we don't know really how long they can carry it for.
Yeah.
And the problem is they're passing it on so
Within
quickly.
the population.
So while they're still alive, that it doesn't matter if one dies because the next one already has it. So it just continues like that. Yeah.
Next to rats, because I heard specifically seals saying that rats die too quickly. If they are rabid, they die too quickly.
To transmit. That is also what we were taught. Incidentally, in South Africa, we also taught that I don't think there's actually been a recorded positive rabies in a bat in South Africa. So the States, Central Africa, North Africa, yes, bats, but here not that much. So it's not something to be super frightened of here, at least, I think.
But still get your vaccinations. Okay, Albie's typing. I see he's got it. You can unmute, Albie. You can talk.
Que fala português. That's the problem. Hi, ladies. Thank you very much. So we did have a farmer that died after a bat scratch at Sun City many years ago, but that was probably before you guys were around. So if you say there hasn't been a recorded bat case in South Africa, that is a bat testing positive for rabies, or because that case was linked to a bat scratch, but the guy died, so there was a rabies transmission by a bat.
So a bat that transmitted rabies, but not a bat that's come into the lab for rabies testing. So
Right.
fair.
Okay.
Yeah. Good. All right.
I have a question.
Yes.
What's the youngest child that you can give a rabies vaccine to?
Oh, where's Linda? Linda, come answer my question. Come answer your daughter's question. Yes. What is the youngest child you can give a rabies vaccine to? Age-wise?
Let's look at the picture. I think 3 months.
3 months.
I'm not sure.
Yeah.
No, I'm not sure.
Okay. 12 weeks or older.
It will be probably the immune response.
Yeah, it's just
all vaccines.
it's not
around 3 months.
yeah.
Well,
Yeah.
So some of the vaccines, but I guess if it's rabies, you're gonna give it.
Yeah. If the risk is gonna be there, yeah. They're a wrap. Yeah. So we'll have to just post about that one. Thank you everyone for joining online. We're gonna close we've got a comment online. And I'm not gonna say who.
Isn't it scary thought that vampire bats, sorry, let me read it out loud. It's from Pierre. Isn't it a scary thought that vampire bats can bite a potential meal provider without them being aware that they have been bitten?
Yeah.
That is scary.
Yeah. So that is the biggest thing about risk categorization in bat exposures. There's just like there's no way of saying, no, I didn't get exposed, because you will never know. And actually, interestingly, the case of the Canadian child, that is the most recent case of death, well, actually, I think the first one in a while in Canada, the child was not known to have been bitten, but they just found a bat in their room. And there was no history of actually bites happening. Yeah.
So tiny.
Yeah. If she's there, yeah, we'll ask Monica.
She left.
She left. Okay. No, we'll find out about the minimum age.
It's the same regime as in adults, with a booster a year later.
Yeah.
But it doesn't give the child age.
Yeah. I think the biggest thing is depending on your risk, and then obviously boosting is so important with kids because of the inadequate immune response when they're first vaccinated. Yeah.
We give them free.
Yeah, exactly. Yeah, because you don't know. And it's interesting, the States, they often will just, like I said, fall back on this, we'll just check and actually in France as well, because that was on the ISTM podcast, is
is if they're not sure about what vaccine someone's had, they're traveling, they get a vaccine, they'll always say, okay, we'll continue the course, but then we'll check the titers after a certain time. And or we're not sure if this person actually had PrEP. Let's check their titers. And that's not really an option for us. Yeah, exactly. Okay.
Yeah.
All right. Good. Thank you, everyone. We're going to stop the meeting online, and then everyone here is going to finish eating their normies. Thank you, everyone, for joining, and we will meet again in Feb next year. And this recording will be made available on our YouTube channel as well, so we'll circulate that. Like and subscribe.
Nice.